It's Dr. Rabaa.
Hello, everyone, and welcome today to the book discussions. Through the sessions of the book discussion, my friends, we will have twice, per week meetings, inshallah. And this is aiming for mainly people who are preparing for May exam. Of course, my friends for November exam are welcomed as well. This is a chance to, just learn from your friends. Also try to present if you want. We are going to go through the 14 modules from 2 books. One very famous book and very basic one, which I will really, really recommend that every one of you will have this book and will practice from it. It's very useful. This is the part 3 MRCOG Essential Revision Guide. Okay, so this is a very, very, very important book. And also the second book that we're going to cover or go through the modules from it. This is the Get Through book. This is a very important book as well. Okay, so in the Essential Revision Guide, you will find that there is introduction, and this introduction is very useful. And then you will find that there is practice of one circuit as example of the exam, right? And in the Get Through, you will find that there is 2 circuits, okay? And also very useful introduction and explanation of the module-wise things and all, okay? And you will have the chance to practice 2 full circuits. That's mean 28 tasks. What we are going to do, like we have done in the previous batches as well, we will cover module by module from each book. Okay, so for example, we'll cover from Dr. Lisa's book 1 module. Okay, that's mean 1 case because it's 1 circuit. We will go to Get Through. You will find that there is 2 circuits, so we will practice the 2 modules from, sorry, the 1 module from the 2 circuits. That's mean 3 tasks. Okay, so if we do that, we will cover the 14 module from the 2 books, and we'll be so happy. Why? The cases actually from the books are very important and have very useful comments on it. That's to help you when you practice with your study partner. And the most important thing that it's very common in exam, very common, okay, that they bring tasks like this, because of course those books have been made by respected, professors, and they are one of the examiners, a group of examiners, sorry, of the college, the old experienced one. Okay, so it's very important that we listen to them. Okay, my friends, are we happy to go?
Yes, ma'am.
Okay, that's very good. And here I would like to invite one of you, my friends, that's to present a task of the teaching. And then after that, I'm going to comment on your performance and what is required in a teaching task. Okay, guys, are we ready for that? Okay, so Dr. Taskeen, hi, dear, how are you?
Hi, ma'am. How are you? I'm fine, ma'am.
Hi, dear. I'm happy, so happy to hear your lovely voice with me in the practice session.
Thank you, ma'am. Thanks a lot.
So will you be ready for the task number 1?
Of course, ma'am. I'll try. I just started preparing for part 3. Inshallah, I'll try.
That will be great. Okay, so here, my friend, look, if you can see my screen.
Mm-hmm.
Okay, so this is for the module 1, as I told you. It's a teaching book, a very lovely teaching book. Okay, so here, this is what they want from you in the teaching task. Okay, you know the role of the obstetrician as a teacher and researcher as well. So here they are testing your ability as a teacher, okay? And in the same time, the communication with your colleague who is junior colleague, right? How are you going to respect your colleague? How are you going to support your colleague if there is difficulty? Okay, that's very important, remember, okay? And you are going to explore what is his needs in the teaching, what he wants exactly or she wants, and then you are going to provide the support, okay, to your colleague, and in the same time teach him or her about what they need. At the end, you need to give also like a resources to study. Okay, so nowadays in the exam they don't bring a straightforward task from the teaching. Usually there will be some, some trick in the case. Maybe that your colleague have a difficulty. Maybe your colleague is the victim of undermining, maybe, or bullying at the place of work, okay? Or maybe your colleague is difficult, okay? Sometimes we have a difficult juniors who doesn't want to learn really, okay? So, or maybe they want to have, a shortcut. They want to be signed off for a procedure, for example, while they can't do it correctly, okay? So here is the task, my dear, for you. Okay. And let's see how we're going to perform. I'm starting your 2 minutes, and when you're ready.
Okay, ma'am.
You want me to scroll down? Please let me know.
Yeah, ma'am. Little down. Consent form is with the task.
Yes, my dear. Okay, here is the form. Okay. Okay, dear, are you ready?
Yeah, ma'am.
Okay, so I'm going to start your timer now.
Okay. Hello, I'm Taskeen, one of the ST5s here, and you are?
Hello, it's me, Rabaa. I am the recent junior who came to the unit 4 weeks
All right.
ago.
All right, Rabaa, welcome. And how are you doing now?
I'm doing great. Thank you very much.
How's everything in the department?
Yeah, I think everything is good, and everyone is supportive. I'm so excited to be here.
Oh, nice to hear. Okay, Rabaa, can you tell me how can I help you today?
I think that you want to go through the consent form with me. This is what I have heard.
Yeah.
Like
We actually will go through the consent form, and we'll also discuss what are the points for a valid consent. And at the end, I shall be providing you with the resources to go through. All right, Rabaa?
Oh yeah, that would be great. I have just, take the consent from Miss Samantha today, and I think I have filled the form. Can you see it?
Yeah, Rabaa, I can
Yeah.
see it. Very well done. I appreciate your effort in writing the consent. Can you tell me how you taken the consent form before also?
Um, Actually, this is my first time. I have seen my seniors take the consent a few times, and they think that it's very easy, just a form, and we fill it down, and that's it.
Oh, well done, or very nice. It's quite appreciable. And did you have the information about the patient whom you had the consent?
Yes, she is 37 years old, and she is going to have a cesarean section for breech.
Okay, all right. Okay, Rabaa, first we'll go through, can you tell me why is this important? Like, why do we take the consent form? Can we just discuss it?
Yes, I think it's a routine part of the procedure. It's a paperwork. It's a routine paperwork.
All right, Rabaa, yeah, it is. But let me add to it, like it's a very important document. It has got a medical legal importance in terms like, for example, sometimes patient may not be happy with the procedure. So we have like this as evidence that we have told the patient about the risks, benefits, procedure. So it will be helpful in case there is any legal claim afterwards. All right? Is it so?
Yeah, I see. Yeah.
Yeah. Also, it helps the patient to again review what is the procedure, what are the risks, and to get a better understanding of the procedure. Okay, Rabaa, is it like how does it sound?
Yeah. It's very logic. Yes, very helpful. Yeah.
All right, Rabaa. And next, there are some points where we should be, we can call the consent as a valid consent. Consent, like it should be clear, it should be legible, it should be, informed one. We should tell the patient about all the procedure and about all the risks and benefits. And also, it should be, the person giving the consent should be a competent one. Can you tell me what we understand by a competent person? Like, can you tell me about that?
Yeah, I think she is an adult, and she can take the responsibility for her actions.
Well, yeah, it is true. Like she has to be, there's some age criteria. Also, the competent person is the one, it's not only the age. Competent person is the one who will understand it, the procedure, or understand the information. Then he can retain it and he can reproduce it as well. All right?
Okay. Yeah.
Okay. Can you repeat this, the criteria which I just mentioned?
Yeah. It's you're saying that it's an adult, a competent patient is an adult who can understand the procedure and the risk related to it, and can recall back the information that we give.
Well done. You're a fast learner. Very nice. And there's not only the adults. Sometimes we have like you can have under 16 years of age patient. In that we check for the like competency also. All right.
Oh, yeah. Okay.
Yeah. Now we'll go together through the consent form which you have just filled up. It's well done. Very nice. And I can see that you have written the patient name, full name, date of birth, and that's very nice because it's very important also in way of the patient identity as well as for the patient safety. Very well done, Rabaa. Then next you have the procedure that it's an LSCS, isn't it?
Yeah.
The lower segment cesarean section. In this, like Rabaa, do you think it would be better if we write the full form of this operation so as to make the patient understand about the procedure?
Okay.
Like we can write it to get like in an expanded form, lower segment cesarean section. All right.
Okay. Yes. Okay.
Yeah.
Okay.
Also, it would be better like if we mention what is the indication. Like you earlier told me, the indication was the breech for the breech presentation. So we can write down she's a primary gravida, what is her gravidity, as well as what is the diagnosis for which the patient is undergoing the procedure. All right.
Okay. Yes.
Okay. Then I can see that you have written very well, like what are the intended benefit. Very well done that you have written in a simple language, which is clearly visible and understandable, that it's to deliver a baby safely through a cut in the abdomen and the uterus. Very nice. Again, Rabaa, in the consent form, for when we fill the consent form, we should avoid the terms like uterus. We should use the language which is understandable by the patient, because the top copy, one of the copies will be given to the patient so that he may understand it fully. Like instead of uterus, we can write womb. Okay. Instead of abdomen, we can write tummy. Am I clear so far, Rabaa?
Yes, you are. So that's mean you need me to write in a late term.
Yeah.
That's good for me. Yeah. Okay.
Do you have any questions till now you want to clear?
No, thank you very much. It's very clear. Yes, I'll take all of the notes that you told me for the next time. Do you want me?
Yeah, next you have written the risks. Very well done. Yeah, in any procedure, we have to make sure that the patient understands what are the risks with the procedure. You have written hemorrhage, then blood clots, emergency hysterectomy. That's very nice. And also, Rabaa, we should also mention about what are the frequent risks and the serious risks, which you have included. And in terms of you have written 1%, it would be better if we write in a numerical form, like if we write 1 out of 100 for the better understanding of the patient. All right?
Yeah.
Okay. Also, I can see I think the percentage which we give, that should be, if we have any confusion relating the percentage, correct percentage, we should be always free to ask our seniors or to check out at the resources. All right. I think blood clots is around 4 to 16 in 10,000. We may check it together. Okay.
Okay. Yeah.
Yeah. Then there's the another column, that any extra procedures. Very well done. Very nice that you have written the blood transfusion risk. Yeah, there can be blood transfusion and we have to take the consent for that. And also, Rabaa, as you have well mentioned about that, there's a risk of injury to the surrounding structures. So in other procedures, it would be better if we write that maybe there may be a need for the procedure to repair any injury if caused accidentally. All right?
Okay.
Yeah. Why is it important? Because once the patient will have this incident, the patient will be asleep and will not be able to take the consent for that procedure. So any extra procedures needed, we have to take the consent from the patient. All right?
Yeah. So
yeah. Then next, you have also written your full name as well as your designation. Very well done. And the date also, that's very, very important. And also you can then sign the patient's signatures. And also I can see that you have just encircled that you have handed over the top copy of this consent form to the patient for her review. Very well done. Very well done. That's good. And also, you have included the type of anesthesia. That's very nice. That has to be mentioned to the patient. And also that will be cleared by the anesthetist because they will be also talking to the patient. So it's very nice that you have written your full name, the date, and the designation also.
Yeah.
So, Rabaa, do you have any further concerns or expectation or any point which we want to discuss or which you want to get clear?
Thank you to your time. Thank you very much. Thank you. That's your time. Thank you. Thank you very much, Dr. Taskin, for the lovely presentation of the task. Thank you. And I really appreciate your volunteering today. That's very good. And you have done a really good job. So would you like to, give me a feedback yourself in terms of reflection? How did you find the task? And how did you find your performance in the task as well?
Actually, it is a quite different task, like how to, teach your colleague and that too with the proper language. I think maybe I may have to elaborate more about the consent taking to explain to the, colleague. And also at the end, maybe there may be some points which we have to sum up, because I couldn't sum up at the end.
Yeah. Okay. So, yeah, what you have covered today is almost, like 90% of the task. Okay. And I think that in the introduction, okay, it could be a little bit short, okay, so you can save the time. You needed just like 1 extra minute, okay, to finish everything perfectly. And I know if you have the time, you will do it. Okay. So a little bit, okay, in the introduction, you may ask your colleague, okay, some questions and give short answers, because your colleague he have some questions for you. Okay. Like today, as a role player, I should have asked you about, do I need to mention the risks that are really rare? How could I be expected to fit everything in the form? If I had included all the risk, wouldn't the patient have refused the procedure? And this is the thing, this is the very important questions, okay, that I was, waiting actually to ask you, but because you were speaking, okay, and I didn't want to interrupt you much. This is what the role player will do in the exam, okay? So the spare time will save you as well in the task, So you have to answer the questions by the candidate. The part of, do I need to mention the risks that are really rare? So what do you think about it? You think that you covered this part?
No, ma'am. I didn't cover this part. Like what type of risks we have to like mention in the consent form? Only common, uncommon, or rare also.
Yes. So the serious rare, okay, should be mentioned, right? How can I expect it to fit everything in the form? So what do you think?
I think the questions or the consent form, what are the like basic requisites, we should be able to fit that in in a short form, in a short language, in a short sentences.
Okay. Yeah. And the most important thing that we use a guidance, right, for the consent form, which is a consent advice from the college. The college have published a consent advice for the elective cesarean section in 2020, right? And we can use the information from it, okay? And we write it, as you said, it should be condensed, right? And it should be to the target, and you should fill everything, the consent form that the ready-made, okay, is designed, in like a very easy way for the doctors just to follow the important point in it, okay, that need to mention. So if I had included the risk, wouldn't the patient have refused the procedure? What do you think about this?
In this, like we have to tell the patient about the risk, but not in a frightening way. Like we have to mention that it's a commonly procedure which we do in the routine.
Yeah.
Yeah, and most of the patients, they don't have the risk. And then we can explain, we can just touch 3 or 4 risks which we are going to tell the patient.
Yes, so it's all about the legalization, right? So yes, it's very important that you have told that, but in a different way. The thing is that the consent need to be informed, right? And the part of the procedure, okay, legalization of the procedure, that the patient understand very well what are the risks, okay, and what we are going to do, okay, to mitigate those risks, right? So this will help the patient to take the decision. So this is very important, to be mentioned, because otherwise the consent form will not be legal, right? If the patient doesn't know about the risk. So here, my friend, let's see what the candidate should do. Highlight the good point in the way consent was documented. Okay, explain the principles of obtaining valid consent. For this part, my dear, you have covered the point number 1. and you have covered the point of the principles of obtaining valid consent, but in this particular part of your station, my dear, I think that you have extended, you know, the discussion of obtaining valid consent, and this was not required. You know, you will always find in the task for the part 3, you will find two, you know, subjects for any station at least. So my advice to you, focus on the main station, right? Anything else, give short answer for it, right? So you have mentioned very well the principles of the valid consent, right? But make it short, please. Okay? Okay?
Like,
So
ma'am, our main task was to go through the consent form and correct the corrections there.
yes, yes, exactly. Exactly. Well done. So you're here for the obtaining valid consent. Okay, you have to mention, okay, the part of the obtaining valid consent or how the consent will be valid, and that's it. Okay, then outline and correct mistakes in the consent. Okay, and encourage reflection and self-directed learning. This part, the last part, this is the part that you missed. Okay, because
Time.
yes, it's time. So you had to cover resources, of course, for the trainee, okay, for the trainee to go to read it. And the resources that we have is the RCOG, you know, consent advice, and for the cesarean section, and also the one that obtaining valid consent, okay? Those are very important that you mentioned to the trainee, okay? Regarding the reflection, because it's very important that the trainee will not feel offended, okay, or undermined by your comments, right? So encourage the trainee that simply that you can reflect on yourself, right? And you can have a piece of reflection, you know, and you can see how would you do that next time, okay, in a better way. So that's mean we learn from the situation rather than blaming the trainee because he didn't have the correct consent, right? So this is when you encourage for reflection, okay, non-blaming, of course, way, and self-directed learning. This is where he will search or she will search for the resources, right? And she read by herself. Of course, information from the RCOG website, the consent advice. Also, you can mention the GMC website as well. It's very important because they have very valuable information regarding the consent form, right? So here, reflection on the task. This is for yourself, my dear. So review the notes that you made before reading the examiner notes. Did you remember the principle of informed consent, patient safety, and giving formative feedback to a junior colleague to ensure learning? Okay. Have you mentioned or you have covered the legible writing, avoiding abbreviation, documentation of risk and alternative to operation, assessment of mental capacity, not taking consent if unable to discuss the procedure and alternative, principles of feedback and supportive approach, going beyond the training patient and the patient safety. So I can see that you have covered as well, again, like 90% of the task, but still you will lose mark in the exam if you go this way and if you didn't manage the time, right? So in order to make it a very perfect one, okay, please just repeat the task again. Maybe you practice the task with your study partner, okay? Put in your mind the point that we said about the missed, okay? That's the resources or the self-directed learning and reflection for the trainee, okay? So please complete your task and you can post it to the group. That will be appreciated, my dear.
Okay, ma'am. Thank you.
Thank you very much. You are welcome. You did great. Okay, so I hope that it was clear, my friends. Any questions?
Dr. Rabaa, can I ask a question?
Yes, dear, sure, you're welcome.
Dr. Rabaa, so if let's say the junior says that, no, how do I fit so much of the information into the limited space? Can I say that we can actually attach a copy of the details of the risk of this procedure, which is from the consent advice from the RCOG that is
Yes,
validated? So we just attach with this paper.
yes, yes, my dear. Look, my dear, this is a very good question. Okay, I'll tell you. Regarding the information from the consent advice, okay? First of all, you have to fill the form completely because the colleague, okay, didn't fill the form completely today, right? So he or she must take care of this point that they fill the full form, okay? They didn't leave any part. Because, for example, the part of the you have give the patient a patient information leaflet, and writing the name of the patient information leaflet was not there, right? So here, okay, the consent form. Usually what you will find in the hospital in the UK, that there will be already, you know, made stickers, okay? And this will be like quoting the numbers of risk, okay, or mentioning the risk from the RCOG, website. A copy also like this. This is summary, estimate the risk of planned cesarean section compared to planned vaginal birth. Okay. In this case, because she is breech, so you can mention that we can give her a copy of the information to compare between the planned cesarean birth and vaginal breech. Okay. And here, okay, from the consent advice, this is the information that need to be covered. And this is very easy and straightforward, as you can see. The form is not too long, right? So here the consent, let's go through it once. The consent form for planned cesarean birth. This is the patient identifier, okay? This was mentioned in our friend consent. Name of the proposed procedure, so planned cesarean birth, and explanation or description of the procedure in layman term. So birth of the baby through a cut in the tummy or in the abdomen in between two brackets, tummy and the uterus womb. The anesthesia, okay, this procedure will require anesthesia, okay, that to ensure that you don't feel any pain. This will be discussed with you by the anesthetist before the procedure. Statement of health professional. This is to be filled by the health professional that I have explained the procedure to the woman, especially I have explained. This procedure involved birth of the baby through a cut in the abdomen and uterus. Number quoted below are estimate only based on the data currently available. And here, estimate of risk, okay? This one, for this one, you will find a ready-made, forms or stickers, okay, and it will be attached to the consent form, okay, so the patient can review it or can read it. Okay, so here the risk of the perineal tear, urinary incontinence, fecal incontinence, urinary tract injury, wound infection, hospital stay, uterine rupture in the future pregnancy, emergency hysterectomy, placenta accreta spectrum, maternal death, even if it's rare or even very rare, so we have to mention this. Risk associated with anesthesia, skin laceration, childhood obesity, asthma, and higher neonatal morbidity. Okay, so here, the rest of the form, I have discussed the risk of this woman, consider they relevant to her, taking into account individual circumstances, risk factors, and plan for future pregnancy, and specify details. I have discussed the risk of alternative modes of childbirth, because for any procedure, we have to mention the alternative. For elective cesarean birth, for breech, we have to mention about the both the procedure of ECV, okay, and trial for ECV if it is applicable to the situation, or vaginal breech delivery. I have discussed the procedure that may become necessary during the cesarean, okay, like blood transfusion, repair of any damage to the organ, or emergency hysterectomy. And here the following leaflet or electronic information have been provided, and you have to specify the details, okay? So your friend there in the consent form in the book missed the name of the patient information leaflet and missed to take this point. I confirm that dismiss. For example, Samantha has been offered time and opportunity to seek clarification on the information provided. Okay, then the information about the healthcare professional, so this is for yourself. Okay, so you have to sign and you mention the date, name in a printed way, GMC number and job title. Okay, and contact detail if it is applicable as well. Okay, my friend, this is for the lady, the consent for the lady. And also it should be signed and dated with the name printed form. If there is interpreter, attend the discussion, because, for example, the woman does not understand English very well. Okay, even the statement of the interpreter should be mentioned. Okay, and then confirmation of the consent on the day of procedure. As you know, in the practice, UK practice, that's the consent will be taken at the time for the outpatient clinic for elective procedure. So it will be taken in the outpatient clinic, provide the patient with a copy of the consent and provide the patient with patient information leaflet, and also you give the patient time, okay, to go through the procedure again or the information that you give her, so she will, be like satisfied, okay, to go to the procedure like this way. On the day of the procedure, like the time when we discuss the preoperative round in the gynae list, you will just confirm the consent on the day of the procedure in the morning, right? Is it clear, my friends?
Dr. Rabaa, can I ask a question?
Yes, sure.
Yeah. So I joined a bit late, so I don't know whether I missed. So here it says that the consent should be taken by someone who can either undertake the procedure or who has been trained to take consent for that particular procedure. So this candidate, the junior colleague, can we say that you should not have actually taken the consent? I mean, I'm not clear on this point.
No, we can't say that. Okay, this will be undermining to the colleague.
Yes.
You need to
So how
advise-
to tackle this?
You are going to advise your colleague, okay, to learn about taking consent, okay, and you provide resources for learning. You advise your colleague to reflect on the situation, okay, because reflection is the best way actually where the colleague can learn from their mistakes, okay, and planning for what to do in the next time so we can avoid that situation. Also, you are going to offer, it's like a volunteer, you offer that the colleague will accompany you next time when you take consent. Okay, dear? But
Okay,
you
thank
can't say, but you can't say, in a rough way that you shouldn't
Yes.
have. Okay, this will be considered as undermining.
Okay, ma'am. Thank you.
Okay, dear? You're welcome. Okay, so we have Dr. Minna. Are you ready, my dear?
Yes, yes.
Okay, so we are going to practice again from another book. This will be the Get Through book. Okay?
Okay.
Just give me a little bit of time, because I don't know exactly the number of the page. Okay. Wait, the
140, 150.
here we go. By the way, my friends, as you can see, the circuit is starting in this book after 150 page. Okay, that means you will have 150 page of information that will be helpful for you guys to learn. Okay, so you can go through it, read it. Okay, so you will learn from the examiners about famous task or how to approach each module. okay, and with very good examples of teaching, examples of managing emergencies, even for audit station and so on. Okay, so Dr. Nadia, you have now the task.
Okay.
I hope you can see it.
Yeah, okay.
When you're ready, I will start your 10 minutes.
Okay. Okay, I think I'm ready.
Okay, that's great. Okay, so started.
Hello, I'm Mina, one of the ST5. May I know your name, please?
Hi, it's me, Rabaa. I am the ST1 here.
Okay, great. How are you, Rabaa, today?
I'm fine.
Good. Do you enjoy being in our department?
Yeah, I've recently joined.
Mhm.
I'm recently joined the unit in the labor ward department, and
Okay.
I'm so keen to learn about the labor management and all. I'm very interested in obstetric.
Oh, that's lovely. That's lovely.
Thank you.
Rabaa, I understand that you are here to learn more about third stage of the labor. Is it?
Yes, that's correct.
May I know any particular reason?
Yeah, I have actually have seen attended different deliveries, and I have seen some of the midwives performing deliveries, and they speak about the gentle cord retraction. I don't know
Mhm.
uh, actually how to perform it, and I have also mentioned some patient would like to have the passive third stage. Some patient need the active third stage, and I don't know what is the difference between both of them.
Okay, sure. We will go through them. And Rabaa, I will start explaining to you, and it's not like any formal discussion, so you can stop me, you can ask any question if you have. And by the end of the discussion, I'll give you some links. I'll connect you with some links so you can learn more, and you can attend to the deliveries, and I'll show you the physiological and the active management, and also I'll show you how you can deal with that. And then you can give me a comment at the end as well.
Yeah, sure.
So, yeah, lovely. So first of all, do you know the stage of delivery?
Yeah, this is the delivery of the placenta after delivery.
Lovely.
Yeah.
Yes, that's great. So usually, as you mentioned, this is a delivery of placenta. So we have two routes. One is physiological and another is active phase, active management of third stage of labor. So usually during the, we will discuss with patient during the mode of delivery that how they want to deliver their placenta. Some of them, they want to have a normal physiological placenta. That means they don't want any interaction, any medications to be given to them to
Okay.
help with delivery of placenta.
Okay.
And we call it as physiological. However, sometimes some of the patients, they are high risk for bleeding, for PPH, postpartum hemorrhage. So in this case, we need to offer them or advise them to use the active management of third stage of delivery to reduce the amount of bleeding. Okay.
Yeah.
So we usually, the main important thing is we usually, as you asked, control cord traction. So after delivery of the baby, we give them time to deliver the placenta itself, or we can itself and physiological one. So we will just wait for the delivery of the placenta. And because it's a physiological one, and we don't give any medication to help them, so it usually takes longer times, and we give an hour for the patient to deliver the placenta. And when we saw the sign for the separation of placenta, like the cord will become longer, and also the uterus will contract and coming down, and sometimes we can see the fresh blood coming as well. So, or a splash of blood coming from the vagina. So that means the placenta is separated. Then we will take you can see my hands, we will take the cord by our right hand, and or dominant hand, and we will put our non-dominant hand on suprapubic, and we will hold the uterus, and we will gently rotate and pull the cord. Am I clear so far?
Yes, yes, you are. And yeah, I just would like to confirm again, the time for the passive is
Yes,
1 hour. So we don't consider that this is a delay until 1 hour.
exactly. You got it. That's perfect.
Yeah.
And
So
then, mhm.
time for the active is 30 minutes, right?
Exactly. Yeah.
Yeah.
You know a lot. That's great. That's lovely.
Thank you. That's
Yeah, you're brilliant. And now coming to the second one, that active stage, we usually use this for the high risk patient and for those that they don't refuse the active management. So for the active management, we usually give them oxytocin, 10 international unit by IM route. Okay. And then when the the baby deliver, then we will inject this injection. We will tell to the patient that we are giving injection to help them. And then we will wait for 30 minutes. Okay. So this injection, this can cause like sometimes nausea, vomiting, and sometimes some cramps. So we will tell to the patients. And then after 30 minutes, not even after 30 minutes, when we saw there is a sign of separation of placenta, as I mentioned before, we can start controlled cord traction. Am I clear so far? Hello, Rabaa?
Yes, you are, of course. Yeah.
Do you have any question?
Yeah, I have seen some of the nurses give some patient symptometry, and
Yeah.
I don't know what is the benefit of it.
Okay. So symptometry is a combination of oxytocin and ergometry. So we call it a symptometry, and we use for the high risk patients for PPH. So for the low risk that they don't refuse any active management, we usually give them symptometry, oxytocin. But if they are in high risk, like previous PPH, if they have overextended uterus, like polyhydramnios, multiple pregnancy, or if they have any like prolonged labor, so we usually prefer to give them symptometry. But we need to rule out any contraindication like hypertension and cardiac disease. Then we can give this medication. So it reduces the amount of bleeding and it's helped for delivery of placenta as well. And then we need to, after delivery of the placenta, we need to calculate the amount of bleeding. And if it is more than 500, that means it's PPH, and we need to start the like incidence report, and we need to evaluate and assess the patient for
Okay.
any further damage. Do you have any other question, Rabaa?
Yeah, I think that you have covered this all. Yeah, so thank you very much. I will try to perform one cord traction, okay, and delivery of the placenta in my next
Yeah.
on call.
Sure. I will first I will deliver in front of you, and I'll show you. Then you can deliver, and I will observe you. Okay.
Okay.
Yeah.
So
Yeah.
yeah. So I need to attend first with you.
Yes. Yeah.
Okay.
And do you have can you please just give me feedback if how I can improve, and I'll give you this links as well.
Yeah, you were really good, and you're so kind to offer me, a chance to attend with you in the delivery. But I just want to ask about resources, any resources to help me?
Yes. So I'll give you the
Time.
resources RCG.
Okay, it's your time. Thank you very much. Yeah. Yeah, thank you very much, my dear. You did well, okay, in that, and I will show you, okay, how this task was, um, marked. So you will see yourself about the reflection of the task and how much did you cover, okay, from the required point. So in the domain of communication with colleague, okay, you had an appropriate introduction, but just add some point, okay, that you, yes, you were very welcoming to the role player and to your colleague and everything, okay. When you ask about everything in the department, how everything in the department, always offer, okay, your help if there is anything, and that you have an open door policy, or my door is open at any time for you, okay. If you need to learn about anything, or if you need to discuss anything, okay. So just say it, you will have one
Yes.
mark for it, okay, and it will be
Okay.
helpful, when you have agenda,
Portfolio.
okay, yeah, hidden agenda that this trainee is suffering from something, suffering maybe difficulty in life, or some circumstances, or difficulty in the workplace, okay. So you will catch this early by asking about how everything in the department and how are you doing, okay, and just mention that your door is open to the trainee, and you're welcome anytime. If there is any concerns or any help, I will be happy to offer it, okay. So
Yes.
there should be a clear structure to the delivery of teaching. Of course, encourage learning, discussion, and question with appropriate verbal and non-verbal communication. I will, advise you. In your technique, you were good. Your teaching is great, but just, on intervals, ask your colleague to repeat what you have said
Yes.
and highlight
Yeah.
it, okay?
Right.
Because
Yeah.
for you, I've tried to help you, okay? When I said about the time of the active and the time for the passive, because this was one of the concerns of the trainee, that they don't know about the time, okay, appropriate time for the third stage. So just, simple question, because usually in teaching, they will bring a medical student to you, okay, in the exam. So at least some information will be easy when you ask your colleague, your junior colleague, about have you got this point? Is that clear? Can you tell me this? Okay, and this take the chance, okay, of course, to comment, yes, as you said, yes, you are a fast learner, great, okay, something like that. Okay, the information gathering check the existing knowledge of the candidate. So your knowledge was, you check the knowledge of the candidate and you check about the definition, so it's fine. Confirm understanding at appropriate interval during the teaching. Okay, so please just work on that. You can make it at least like 3 times, you know, during the
Yeah.
time of the teaching. Applied clinical knowledge, understand the correct definition of the third stage of labor and knows what is defined as prolonged second stage. So you have done this. And correctly identify which element belong to the active and passive stage of the stage of management package. Give appropriate feedback and develop learning plan using knowledge of the curriculum and assessment tool. So here in the safety, the point of the counter traction during the controlled cord traction of the umbilical cord was 1 point of safety. And also the contraindication to the symptometrin was a point of safety. So well done. Okay. And here is the examiner notes. Okay, so any questions, my friend, here? I think this task was good task, right?
Yeah, I think it was.
And
Actually, when I saw this and it was, oh, what I have to say in this task.
no, you are perfect, mashallah. So yes, you did well. Okay, so who is our next volunteer today? Thank you very
Dr. Rabaa,
much.
I'd like to give a try.
Yes,
And
sure.
Sarah.
Hi, Dr. Sarah. Yes, I'm happy to have you here, Dr. Sarah. Okay,
Yeah.
so Dr. Sarah, just give me 1 second. I have to scroll down, okay, to the next circuit so we can. Here we go. So please read your task. And your task is a teaching session.
Is there any more questions?
No, this is a part where you have to cover. Okay.
Okay.
So there's 2 parts: consideration of and teaching style, details of how to measure the sepsis bundle height, and where to auscultate the fetal heart. When you're ready, please let me know so I can start your 10 minutes. Try your best, okay?
Okay.
So even if the task looks like, you know, new style of task, just, you know, try to get your best. Calm down because you'll find this in the exam for sure, okay? And try your best on how to approach this.
Okay.
Okay.
Can I start, Dr. Rabaa?
Yes, sure.
Hello, I'm Dr. Sarah. I would like to discuss regarding how to setting up a class for 20 students of medical students regarding this topic of how to manage a case of a small for gestational age.
Yeah, so Dr. Sarah, from what you can see, your task is to prepare a teaching session, okay? So please tell me, where are you going to do the teaching?
Okay, so I'd like to gather these 20 students in a place that is comfortable with whiteboard and also a marker pen so that I can draw and also illustrate the diagram on the whiteboard. Or if they will prefer like a laptop, okay, that has a projector that can project into the whiteboard, then they will be useful as well. Okay, I will gather them and make them to become to sit in a circle. Okay, so that everyone can actually participate in how to give their opinions and give their ideas on this topic. So I will actually ask them to brainstorm with this case that we have, what are the risk factors of the patient. So after they have actually give their opinion, like for example, the patient is a smoker and they smoke 20 cigarettes per day, and according to our guideline, whether they are minor risk factor or they are major risk factor. So after, I have gone through one round where everybody voice out what are the risk factor they can pinpoint, then I'll make a conclusion so that with this teaching style, they can remember better.
Okay, so this is how will you incorporate the case into the teaching?
Yes.
Or do you have any other idea? Because you are required to, discuss this particular case.
Okay. Can I scroll up and see the case again?
Yeah, sure.
So with this case, I will project to the whiteboard, and then, with the background of this case, they can actually discuss and brainstorm what are the possible anticipate problem. Okay, like whether what are the risk factor to this small for gestational age? What are the possible causes of small for gestational age? And then
Okay.
after that, yeah.
Yeah, it's okay. So what component of the obstetric abdominal examination will you teach?
Okay, so for the abdomen examination, I'll guide my colleagues or my nurse to actually get a puppet so that we can have the abdomen examination, that I can demonstrate how to do an abdomen examination. So first of all, when we measure the symphysiofundal height, we will use the measuring tape. We will turn to the side which is the inch, okay, not the centimeter, so that we will not be biased. First, we palpate the pubic symphysis, okay, which is the landmark. Okay, and then we will palpate the fundal height and we'll put the measuring tape on these two landmarks. And then we will turn again to the centimeter side to record down what is the symphysiofundal height. So after this, I've demonstrated, I will invite the students to actually try on this puppet, so that everyone will have a feel of how to feel for the body landmarks, and they can actually measure for 32 weeks, how much is the centimeter, whether there is any discrepancy from the centimeter as also the 32 weeks. So with 32 weeks, we will expect that the centimeter will be 32 centimeter. So I will from time to time invite questions from the 20 students, whether they have any queries, if they would like to ask further questions, so that this is a two-way teaching and not a one-way, so that it is an interactive session. Other than that,
okay, so I will just need to ask you now, is that what are you going to cover on how to perform the obstetric examination?
okay,
So
so
because
with the abdominal,
I can see that you covered how to measure the Simpson funded height.
okay, so
But you didn't tell me how to do the
abdomen examination. Okay, abdomen examination will include a general and a specific abdomen examination. From general examination, we will feel for the tummy. So there is 9 quadrants in the tummy, which is the hypochondriac, epigastric, left and right hypochondriac, and also the lumbar, right and left, okay, and also the suprapubic and left iliac fossa. So with these quadrants, we can actually go around it and then to feel whether there's any pain, any tenderness, any mass, okay. And then we will, before that, look for any signs of the evidence that is suggests of gravid uterus, such as if it is a primary gravida, then we will see the line, the red lines on the abdomen, okay, and if it's a multigravida, then the linear alba line, okay. So after that, we will actually feel with the fundal grip and also the pelvic grip. So once we have certain the fundal height, we will actually go to the fundal grip and then grab how much, whether the fetal parts, okay, whether the presentation of the baby, whether it's a longitudinal line or transverse line or oblique line, okay. And then by doing the fundal grip and pelvic grip, we will know the line. Then after that, we will see the fetal parts, whether it's on the maternal left or maternal right, by pushing one hand, okay, to the right side and feel whether there's any parts. And so as well, similarly on the other side. So this will be demonstrated, and then the 20 students can have a hands-on on the mannequin later on. So this will be a specific examination for the obstetric abdomen examination. So this will followed by auscultation of the baby heart rate. So we will use a peanut, which to hear the baby heart. So we will actually need to identify the anterior shoulder of the baby. By putting the peanut on the anterior shoulder, then we can actually listen for 1 minute the baby's heart rate. So we can know how much is the fetal heart rate. The normal one will be 110 to 160. So I'd like to invite them to have a try. Well, first of all, it might be difficult, but with practice, it will be easier and easier. So after we have actually gone through the basic examination, then we go back to the case that for this lady, whether if we are to find out that the patient has a small for gestational age, what is the next step to do? So I'll go again with the students one by one, whether they can suggest of any idea, and then whether we can, if they have any problem with listening to the fetal heart rate, they can use a daptone to actually ascertain the fetal heart rate. So with the patient, we suspect, midwife suspect that the symphysial fundal height is on the lower side, then we'll need to refer to the tertiary center. to have a checkup. Okay, it is important that this patient need to be re-stratified. Okay, and a serious scans need to be done, especially from 28 weeks onwards. Every 2 weeks, we'll monitor the estimated fetal weight, the fluid, AFI, as well as the Doppler, which is to see that the blood flow, whether there is any high in the positivity index, that is suggestive that maybe there is a placenta insufficiency.
Okay,
So with that,
your time. Thank you.
okay. All right, thank you very much.
Yeah, thank you very much. Okay, so thank you for attempting the task, and I would like to hear your own reflection.
Well, this
How did you
case,
find the task, and how was your performance like this?
because it's more to like I'm the one keep talking, so I don't have like an outline like what to talk next. So it's a bit scary to me.
No worries. No worries. It's like, sometimes again, it's as we said before, you are performing a task in the RCOG hospital, right? So part of the activity of any registrar, one of the responsibility actually is a teaching, right? So you've been asked to have, this teaching opportunity and discussing, or in particular, to apply to this case, right? About the certain school teacher, right? And very good from you that I can see that you know what are the 2 points that should be covered here. So the task was you have 10 minutes to discuss how you would teach obstetric abdominal examination, including consideration of sitting and teaching style. Okay, and here they are testing your knowledge of how to deliver, okay, or design a teaching session. Detail of how to measure the fundal height and where to auscultate the fetal heart, right? So this is your main task first, is how are you going to teach the obstetric abdominal examination, right? So there are different styles of teaching. So for this particular group of candidates, you have 20 candidates of undergraduates, okay? And this large number, it will be very difficult actually to run a teaching session in the antenatal ward, for example, right? So yes, you have advised that you may find a place, okay, for the teaching and with equipment, as you have said, okay, and this equipment that to help you deliver your message, right? You have chosen, okay, the way of using a projector and a whiteboard, right?
Yeah.
Yes, okay. You can also divide the candidates, because they are 20, okay, into small groups, right? Is that correct? Yeah. You should have other facilities in your teaching, right? Examination chart, okay? The obstetric abdominal examination chart should be there, should be available, okay? And also the growth chart should be available for you as well, right? Because they will be asked part of the simple fundal height measurement, okay, that you should plot that on the customized growth chart, right? Not the population growth chart. So this should be also available. Okay, those are students, so they can't really touch the patient. 20 students touch one patient. This would be very difficult, right? Situation. So it's better that you have the simulation, okay? Simulated teaching, like having a mannequin, okay? Or you do it in the skill lab, right? So that's to help you, right? Practically to apply what you are going to teach. Is that correct?
Yeah.
Yes. Okay. So here are the questions of the examiner for the task. Okay. If not covered by the candidate, then you should ask the following. Where are you going to do the teaching? Okay, so this was the point that I prompt you for it in the beginning. Okay, because it was here in the task. Okay, that how would you teach obstetric examination? Okay, consideration of sitting and the teaching style. Okay, so you have to mention the sitting and the teaching style, not to go to the topic, you know, directly. So that's why I asked you the question, where are you going to do the teaching and how will you incorporate the case into the teaching? Okay, for that, it's okay, but I will advise you just to have mentioned some other resources of teaching, right? And the presence of chart and presence of mannequin, okay? So how will you incorporate the case into teaching? Okay, for that, you can have it like a case-based discussion, and it's one of the styles of teaching, right?
Mm-hmm.
You remember from the part 2, the teaching 1, case-based discussion, right?
Yes.
Yes, it will be also good, okay, to assess the background knowledge of the candidates, right? And to start, okay, step by step with them, right? You can do it as a brainstorming as well. So when you mention some of the teaching styles or teaching tools and methods to the examiner will know, or you will be sure and satisfied that you know already types of the teaching and the styles of teaching, right? Then you come to the point, what component of the obstetric abdominal examination will you teach? So here, this was my question, my dear, and this is very common, you know, mistake in the techniques, that candidate hear the question here, and I'm not saying listen, okay, from the examiner in structured discussion or in a teaching like this, and they start to answer something else, okay? So my advice to you, whenever you have examiner asking you questions, write it down, okay? If you have the face-to-face exam, please write it down. Even if you write with abbreviation, okay? You will have the notes and you will have the pencil with you. So write quickly, okay? Used to write, please. And practice this during the sessions. So write down, okay? Whatever is asked. Why? Because you have to look to the question and remember, when we start talking, we are human beings, you know, and we tend to forget actually, okay, the point. So maybe the talking will take you to another point, which is not required. So to make sure that you have covered the question, look at the question again, okay? So I have helped you by, you know, directing you that, how about the obstetric abdominal examination, right? Because you were drifted away from the question. But please write it down. And this is advice for you, my friends, all of you. Please write it down. It will be much easier, okay? Explain how a semestral fundal height is measured. So for the point of the examination, okay, I will, you know, go through it now with you, but here is the marking, okay, for this station. And see, my friend, how much will you get? I need you, okay, to mark for yourself, okay? So there should be a clear structure to the delivery of teaching, and choose appropriate setting, avoiding real patient, okay? That's why he said undergraduate, for such a big group, but allow practice on models and feedback. Okay, applied clinical knowledge. Obstetric examination of the abdomen is basic skill to the candidates, right? That should show familiarity with the steps. Develop a learning plan at the end of to reinforce the teaching. Safety. The student should know how to take consent before examination. Okay, this is a safety point. So whenever you have a teaching of any skill, a skill of forceps delivery, a skill of abdominal examination like this, a skill of stitching a tear, anything, before you do anything, start by introducing myself to the patient, okay, and take consent for the examination. Right? Clear?
Yeah.
It's a safety for any skill, okay? So to take consent before examination, because you are teaching your student, right? So teach them from the start correctly to take consent from the patient, verbal consent, okay? And have a chaperone present, okay? Having a chaperone, this thing you say every time you have a patient, right? In the simulated patient task. Every time you say, after your consent, okay, or if you allow me, I would like to examine you in the presence of a chaperone, right? So please don't here. And is able, a next point of safety, is able to describe the correct technique for the semifundal height measurement, okay? So for this point, you can use the skill lab, my dear. This is what you should do. You can use a skill lab, and if it's not, okay, you can use, for example, if there is a place, you know, a special place in your hospital or in your setting to deliver meetings or to deliver teaching, you know, sessions like this. So you can use it, it's fine. Okay, you just inform the managers and they will, you know, make it ready for you on the time for the teaching. Okay, so here, my dear, the candidate should be able to explain where to auscultate the fetal heart. Okay, this is the examiner notes. Given the large number size, teaching in the clinical setting, such as the antenatal department, would be inappropriate. When learning practical skills is important for the participant to actively take part, this could take part the form of an introduction and demonstration from a teacher, followed by practice on a model by student with feedback. An outline of obstetric abdominal examination is provided below, and models are available for measuring for the semifundal height, and the student could be asked to plot the gross on the customized chart. That's why you have to mention that your tools should be ready and available. This could be related back to the clinical case, which would provide an opportunity to teach the reason behind the management of intrauterine gross restriction. At the end of teaching, the student should be directed towards opportunities to reinforce their learning, such as following a doctor or midwife in antenatal clinic and practicing obstetric examination. So this is what, okay, required for you to cover a teaching station or a teaching session when they ask you to design a teaching session, okay? Some cases like this came in the exam, like, for example, teaching a group of candidates or discussing injury, for example, to some organ in this you know during surgery, in the laparoscopic surgery, or teaching electrosurgery, very famous, recall. Okay, so you have to remember here, my role is a teacher, so they are testing me on how to deliver a teaching session, and if it is include a practical part, so I would remember really and describe what I'm going to do in real life. Okay, my friends? Okay, so the obstetric abdominal examination component, my friends, so please remember the point because it will be part of the safety. Wash hands, introduce yourself, obtain informed consent for the examination. Okay? This is for any examination you teach to any candidate. Even if you have one student and you have a model in the exam and you ask it to do, do teaching or to perform a teaching for any skill, any particular skill, remember washing hand, introducing yourself, and obtain informed consent. General well-being, because we start any examination by general examination, okay? So patient hands for swelling, pallor, pulse, and blood pressure, and any CRT, face jaundice, for you're looking to the face for jaundice, anemia, and periorbital edema, leg edema, okay? Inspection, position patient as supine, and expose from the sternum to the pubic symphysis, abdomen distended, consistent with the pregnancy of an appropriate gestational age. Fetal movement should be palpated, should be inspected first and then palpated. Surgical scars, if present, like laparoscopy or appendectomy or any previous, of course, operation. Sign for the pregnancy, like the linea nigra or stria gravidarum. Palpitation, ask for pain before starting. Check the lie relationship between the longitudinal axis of the fetus and the mother, and either it's longitudinal lie, oblique lie, and you can explain what this, and the transverse also explain. Okay, feel the maternal abdomen, okay, to feel which side is the back, which side of the abdomen feel more full and similar to the smoother surface. This is the back, and this is compared to other side where limb can be felt, including movement. This, okay, will be, of course, the face type. Presentation, identify the anatomical part of the fetus, which is closest to the pelvic inlet. This could be cephalic breach or malpresentation. Limb is felt by placing the thumb and finger in one either side of the presenting part. Engagement, see how many fifths is palpable. Divide the fetal part, the fetal head into 5 parts, okay, and 1 finger width, that's equal to 1/5. If all of the fetal head is felt in the abdomen, like fifths palpable, okay, 5th over 5th palpable, this okay, should be documented. If 2 fingers width of the fetal heart is felt in the abdomen, that's 2/5, of course, and this means engaged. If none of the fetal head is felt in the abdomen, that's 0/5 palpable per abdomen. The head is engaged when the widest diameter, which is the biparietal diameter, has passed through the pelvic brim. Teaching the symphyso-fundal height, palpate using the ulnar border of the left hand, moving from the sternum downwards. Locate the fundus of the uterus by feeling firm, round. Locate upper border of the pubic symphysis and place the tape in upside down to avoid any error. Start from the ulnar border of your left hand at the fundus and measure down until you reach the pubic symphysis. Measure the distance in centimeters, and the distance should correlate with the gestational age, plus or minus 2 cm, but can be measured more accurately on the customized gross chart. Auscultation, once you have identified the lie of the fetus and where the back is, listen over the anterior shoulder of the fetus. Use some gel and, of course, the Doppler or the sonic aid to listen for 1 minute for the baseline fetal heart. Finish, okay, of course, you have to wipe the gel away from both the patient abdomen and the sonic aid probe. Clean the sonic aid probe, wash hand, thank the patient, offer help to sit back up, and discuss finding with the patient and reassure her and summarize your finding. Okay, dear friends, is that clear so far?
Yes, clear.
Okay, so I hope, my dear friends, that you have enjoyed the session today. Okay, and for every module is important because every module will be presented as one task, okay, in the exam. So I know, for example, some modules takes a lot when you study, a lot of time and effort and a lot of study, like for example, the maternal medicine module. But however, this will stay one task in the exam. Teaching also is one module that will be presented as one task in the exam. So please, my friends, take care of the teaching, okay? And you should practice, okay, some different styles of the teaching, okay? So here, I will review with you, my friends. Approach to the teaching station, okay? Here, there are 3 core components of any teaching event: the environment, and the teaching or demonstration, and the summary. Okay, so as we said, you are in the MRCOG hospital, okay, and you will be required to do any task required from you. Sometimes you are in the labor room, sometimes you are in the ward, sometimes, okay, you will be also like this, preparing to deliver a task, maybe in a separate room, a meeting room, maybe in the skill lab, according to the availability, right? Okay, and what kind of teaching station are likely to come up in the exam? Okay, so the most likely teaching station to arise will include teaching a practical skill, teaching the management of emergency, or teaching a non-technical task, and teaching about particular clinical condition. Teaching a particular practical skills, okay, like for example, ventouse or forceps delivery, breech vaginal and laparoscopic entry, or fitting a ring of shelf or a shelf pessary. Those are very important. And I will add, for the things that recently came in the exam also, something like teaching phase presentation, mechanism of labor, okay, and sometimes they give you a doll, okay, where you can, demonstrate the teaching for this. And you have also stations, some stations where you will be asked also to teach for the surgical knot. Okay, so practice, my friend, the skills, please, as much as you can. You can use some tools from the hospital. You can use a doll and a pelvis. Okay, you can have the forceps or ventouse and try to practice with your colleagues. Okay, so you will master the technique. Okay. For the pessary station, I am going to share one video, okay? It's demonstration of one task about the pessary insertion. So I hope it will be helpful, guys, to you as a resource of this station. Okay. So here also teaching example of management of an emergency, like postpartum hemorrhage teaching or management of eclamptic fit. Sometimes also they will ask about teaching of CTG. Okay, so be careful of such a station that might appear in your exam. Teaching of non-technical task, like taking consent for an operation, okay, like the first case that we have practiced today. Teaching about a particular clinical condition, okay, like HELP syndrome, or teaching about infertility or about labors, all the stages of labor and complication of labor, like, for example, inverted uterus, like retained placenta. Be ready, or cord flaps. Be ready, my friends, okay, to teach anything that might appear in the exam, even without tools, okay, like you don't need to demonstrate, because this is actually an emergency or a situation, okay. Like teaching shoulder dystocia, okay, can come with model, sometimes not, okay, but you have to be ready for all of such stations. Good practice in teaching, okay. So read the instruction for the task station carefully. What are you to teach? Very important, because my friend, sometimes he will ask you particular part, okay, of the topic. For example, he doesn't want you to teach small for gestational age, right? But he wants you to explain a particular part to the student, right? Some other station, for example, he wants you to explain medical management of postpartum hemorrhage or surgical management of postpartum hemorrhage. He doesn't want you to go all the postpartum hemorrhage, protocol. So just be careful of what is needed exactly, okay? In order, to have a good time management and actually to be to the point. Introduce yourself and build a rapport with your colleague. So what is your name and what is the level of training you are in? Set the environment, like place yourself close to the learner. This is in the real exam. Place probe, correctly between you. Explain to them what are you going to teach. and why is this topic that you are teaching important for them, and what do they know about the topic already. So by checking the knowledge, okay, you will have a mark. Explain what you expect from them during the teaching. So you wish them to stop you and ask questions throughout, and you wish them to demonstrate a practical skill after you to show them how it is done. So this is, my friend, this is of course when you have a props, okay? Deliver the teaching, okay? And close the teaching, invite questions, summarize that you have taught, and remember always that you suggest resources. And if your colleague in difficulty, you have to offer support to your colleague. Please remember that. If your colleague have done something like he didn't do things correctly, so please remember again that you are guiding the colleague to reflect upon themselves and for search about resources and attend other opportunity so they can build on their skills. Okay, thank you very, very much, my friends, and I hope that you find this useful. Okay, I will be waiting for you, my friends, next Monday, and we are going to discuss core surgical skills. Sorry, no, next Wednesday. Thank you very much for the surgical skills. Next Monday will be for post-operative, okay? Thank you, dears. Same time, my dear, same time, that's 11 a.m. GMT, okay? All the information that are found on the group and the common group for the practice, okay? Thank you. Take care of yourself. Bye-bye.
Thank you. Bye.